That's a very hot topic because in the US now we have 4 approved JAK inhibitors. So the easiest way is to choose for those that have a severe thrombocytopenia, define a platelets below 50,000 because there we have only one approval, Pacritinib. So patient that would have a severe thrombocytopenia, we have clearly a choice. It's an agnostic line approval without any front line, second line. Then we have 3 JAK inhibitors approved for patients that would have platelets over the number, which is JAK inhibitor Ruxolitinib. That's the first where we have a mature data that goes over a decade, including some possibility of survivals, although no powered studies. Then we have Momelotinib, which was the second largely studied on the largest patient population that already have data on the longer term follow-up in almost 1,000 of them. And then we have a Fedratinib, which is to me a fantastic second line option for people that would have a normal counts. I mean, platelets that would be good, solid over 100, and then very nice anemia not present because they cause anemia and thrombocytopenia. It's quite myelosuppressive. So that would be fantastic second choice. For frontline patient that would not have any counts issues, so no anemia, no thrombocytopenia. I think Ruxolitinib is the strongest JAK inhibitor, so patients with large spleen and symptoms, that would be a first choice. Unless we have the concerns for anemia, where we come into the question if patients have a borderline anemia or hemoglobin of 10 or let's say above 8, which one to choose? Well, Momelotinib definitely insignificant anemia. If there is anemia that we believe would not be tolerated for transfusion support, let's say older patient with cardiac comorbidities, pulmonary hypertension that would decompensate, I would probably also choose Momelotinib in this patient. Everything else would be still very well suited by Ruxolitinib. We have data using lower doses for borderline anemic patients that have excellent efficacy and safety. However, there's more and more coming from Momelotinib in terms of a safety and efficacy in these subgroups, including novel studies they are running in with the combination, for example, using luspatercept or others. So the field may be moving, but for now, I think because of the longest data on Rux, people will still choose this inhibitor. Momelotinib plays a huge role for patients with anemias. Fedratinib, excellent second choice with good counts, and Pacritinib has a role for frontline low platelets. For second line, of course, we know the designation, but second line could be used across regardless of the platelets.